Good morning. We continue revising chapter 9. Uh, Today we shall speak about the causes of diseases, definition and the condition, and we shall try to determine and define main terms related to disease development, related to manifestation of clinical science, treatment, and related to process of rehabilitation. So, what may be the understanding? What do we call the cause of disease or health damage? We call the cause of disease a factor that, alone or in combination with other factors, can condition the development of disease, the clinical manifestation of its signs, and can lead to a positive outcome or to death. So when we are speaking about concrete reasons, we speak that the reason or the factor which is decisive for the development of pathologic condition may be alone, acting alone, or may be combined with different factors or cofactors. In case of infections, we speak, for example, of basic infection. Hello. We speak about basic infection and we speak about co-infection. So co-infection is when we have some additional infection, different infection agent. For example, in case of hepatitis B or C, hepatitis D may be co-infection. So mostly, factors which lead, which provoke or condition the development of pathologic condition, these factors are working in complex. There may not be detected the only factor, the single factor which conditions the development of disease. Or chronologically, we may say that the starting factor which conditioned was the concrete and defined one, and then it activated the chain which resulted in insufficiency, in dysfunction of different tissues, organs, or organ systems. For example, flu can provoke the complication of chronic diseases, which may result in new diagnoses. For example, in respiratory insufficiency. In this case, we say that flu was the factor which provoked the development of this disease, the factor which provoked, but when it appeared, this factor, patient already suffered from chronic diseases, for example, atherosclerosis, for example, arterial hypertension, overweight or obesity, diabetes type 2, or different factors which coact when this provocative factor acts. And the new diagnosis, for example, respiratory insufficiency or heart insufficiency or cardiac insufficiency, will be later diagnosed based on the interaction of flu and chronic diseases. So we say that factors act alone or factors act in concert with other factors. The factor may increase the risk to be infected, for example, but only rarely they are alone and absolute. Okay? For example, in case of COVID infection, you see, when we are evaluating the mortality rate, not morbidity rate, but mortality rate of COVID infection patients, we are taking into consideration the accompanied and basic diseases. So we have basic disease, we have underlying disease, and we have the factor which provokes and activates the silent disease. Okay, so we say that when we are composing death certificate for patient, when we are filling this death certificate, we have to indicate which was the concrete reason of death, what provoked the activation of pathological changes in tissues, and what was the role of chronic diseases in this lethal outcome. Okay, why do we need to define the concrete reason of death? We need to define to find out the mortality rate of COVID infection or any other infections, right? If we want to compare COVID infection with other infections, with viruses, with flu, with seasonal viruses, for example, or with different infections which have high mortality rate or moderate or mild mortality rates, we have to find out what was the concrete role of COVID infection in this mortality. Okay, and then we are analyzing the quantitative data, and then we are concluding the basic characteristics of infection. Okay, that's why we say that in research methodology we are analyzing quantitative data very carefully in order to find out what is the concrete portion of infection in the lethal outcome. Together with quantitative analysis, we're taking into consideration qualitative analysis. Why do we need to take into consideration qualitative data? In order to reconstruct the picture of infection. We don't only treat patients according to symptoms, we also work on process such as psychological rehabilitation. Because if the infection is severe, if it's highly contagious, and if the mortality rate is moderate or high, of course, and it's natural and logical that patients are emotionally predisposed. It's very stressful for them, and we say that mostly we need to treat both clinical symptoms, and at the same time we need to treat psychological aspects to correct behavior, to correct the possibilities of organism for a positive outcome of treatment. A lot of articles are pressed in special scientific journals which describe the psychological status of COVID-infected patients, which evaluates the role of stress in the process of treatment of COVID patients, and which also studies accompanying disorders which may be lately developed. As you know, healthcare management systems and disciplines, and one of them is public health, which is based on research activity of professionals, of doctors, of researchers. Public health is very strongly related and connected to different non-biomedical disciplines, such as economic, such as psychology, such as demography, and different other disciplines. What is most important to study is that after the successful treatment, what will be the complications, not only from the very medical point of view, but also from economical point of views, from psychological point of views, from demographic point of view. That's why we say that, for example, depression, which is frequently evident after pandemic and epidemic situations, depression is a disorder which should be very carefully treated and studied in a detailed manner. We remember, and let us revise the question, that we do not call diseases the psychiatric disorders. We call them disorders, right? Because to call something disease, to define something as disease, we need to have morphological findings, right? For example, some changes in tissue composition, in light or confocal or electron microscopical pictures. So that's why we call them not diseases, but disorders. And one of them is depression. So we can study the changes in electronic activity of brain in patients which are depressed during and after pandemic situations. And at the same time, we are looking for the ways of correction of psychological rehabilitation of such patients. That's why we say that if we need to know the concrete factor or factors which provoked the manifestation, the development and clinical manifestation of disease, the only reason why we need to know it is to receive possibly positive outcome, because treatment does not end at the hospitals. We have very important part of treatment, which is rehabilitation, and that's why follow-backs are very important for observing the final product of treatment of patients with different nosologies, with different diseases. So we have very important topics which are main factors which determine the disease, which are contributing factors which determine the development of disease and clinical manifestation of its signs. And what does it mean? Contributing factor. Contributing factor acts in concert with one or more necessary factors to increase the probability of an occurrence of disease, of a development of a disease or disorder. We are including also behavioral changes, right? So that's why we say disease or disorder. Acting alone, contributing factor need not be necessary, as a disorder may occur without it. Okay, so we can say that contributing factor is additional factor to main factor. And what is sufficient factor? Sufficient factor usually comprises a complex of one or more necessary factors and contributing factors that together can trigger the occurrence. So you see why we are defining these different sorts of factors, in order to understand the essence, the main character, the main nature of disease or disorder better. And what is necessary factor? Necessary factor, as you can already imagine based on your understanding of contributing and sufficient factor, necessary factor must present for a disorder to occur. So let us speak about three main sorts of factors. Without necessary factors, the disorder will not occur. Okay? For example, you have here very concrete example in your textbook. In case of Mycobacterium tuberculosis family must be present for tuberculosis to occur. Without it, tuberculosis does not occur. Okay? So we also have some contributing or sufficient factors, but necessary factor is very important. What is the role of comparisons in our case? Causes of diseases and disorders are often studied in comparison, in groups or reference groups, but comparison of groups is seldomly straightforward. Why do we study them in comparison? Because to take into consideration the possibilities of the same Mycobacteria tuberculosis in the possibility of different toxicity, different development in different organisms. So the response of an organism on the same irritating factor, on the same contributing factor, on the same sufficient factor, on the same necessary factor, the response of two different organisms will differ. Even more, the response of the same organism in different contexts will be different. By context, I mean time context, organisms' acceptance, what is the health status of organism during when these factors starting act, right? What is my health status? Is it satisfactory, more, less? So that's why we have to measure both the role of factor and the response possibility of organism. And we have to find out some association between association itself and causality. The association between measured factor and disease as endpoint, may express three associations. And we use these three associations in order to predict the disease. First one is that the association is causal. It means that variable E leads to development and clinical manifestation of disease B. For example, cigarette smoking and bronchial carcinoma or lung cancer. There are some evidences that show the direct positive correlation between smoking and cancer development, and there are another surveys which say the opposite thing, that not in all cases the correlation is positive. You understand what does it mean, positive correlation, right? Positive correlation means that when the changing in variable E results in the same changing in another variable. For example, if variable A is increased and variable B is increased also, this is called positive correlation. But if A is increased and B is decreased, or A is decreased and B is increased, we call this negative correlation. Another possibility is when observed variable is the intermediary part of the causal chain. Such factors are often called intermediary variables. They can be assessed as risk factors as they are associated with disease, but they may also be endpoints in a study where the main interest is to examine why the factors vary. Such variable may be called surrogate endpoints. Another possibility is when the observed variable is associated with an alternative factor, which is a real cause of disease. For instance, alcohol consumption may be associated with bronchial carcinoma, but cigarette smoking is a causal factor. Okay, so alcohol has a predictive power, and you can predict the concrete possibility of disease development, but this depends on the association between alcohol and cigarettes. Not the alcohol as a single factor is a causal, is a reason, is a factor which provokes the development of bronchial carcinoma. Okay, so the questions we must ask ourselves when facing an association are next. Is the association a random or chance finding? This is first main important question. Another question is the association expressing a systematic error, a bias, either in selection of the sample, taking part in the study, or because of the measurement methods being used? Another question, can this association be explained by another factor or confounding variables? It's also very important to take into consideration. So when we are assessing causality, we have to discuss the following issues. Strengths of association. How concretely these associations are related to the development of disease and to clinical manifestations of signs. Consistency, specificity, temporality, biological gradient, biological plausibility, coherence, experiment and analogy. They are listed in box 9.5, so please revise them. Of these 9 issues which are listed, only the 6 has to be fulfilled with no discussion. One must be able to show that the factor in question was followed by the disease and not a consequence of the disease. Why do we say that research is very important, of primary importance, when we need rapid answers and new information? Because research gives us detailed understanding of strengths of association, how directly the necessary factor or the sufficient factor or a contributing factor are related with concrete clinical manifestation of the disease. Why do we need to know this? To prevent or to build a protocol, treatment protocol. So treatment protocol for us is elaboration of measures which will stop the replication of virus in our case, stop the replication of virus. And the next step is total elimination of virus in order not to give to infection the chance of reoccurrence. So one thing is prevention, some epidemiological measures in the chain of infection, for example, isolation, wearing of special preventing facilities, the social distancing in this case. Next step is elaboration of treatment protocol, and inside this step we have one direction which is related with stopping the multiplication of virus, which will make milder the clinical signs, and total elimination of virus in order for positive outcome. And then we are checking in each case, in case of each patient, how the sufficient factor or contributing factor were acting successfully or not from the point of view of complications, because we may eliminate the virus totally, we may resolve the clinical manifestation and all clinical signs, but the activated silent diseases may result in complications. That's why we say that when we are filling the death certificate, we have to point the concrete reason of death, of lethal outcome, and the role of chronic diseases in the lethal outcome. Maybe chronic diseases were activated, maybe some pathological mechanisms were silent, and the viral infection provoked the activation of this pathological machine. Okay, so you see, that's why we need rapid research and rapid accumulation of new research data in order to make it possible to understand the nature of viral replication, the development of different clinical signs and symptoms, the possible ways of elimination, and the positive process of rehabilitation. But this is only physical assessment of patient. After this, we speak about the psychological rehabilitation because most of chronic diseases may be accompanied by pain. They may lead to a development of a depressive behavior, depressive intonations, depressive reception of reality of the surrounding world. So one thing is to treat symptoms and reasons, and another thing is to give patient possibility to recover fully. And the last thing is economical factor. Last but not least, as people say, because economical factors strongly determine our health status. Because if we are not rich enough, if we form part of societies with low income, we cannot participate in different preventive public health programs such as screening, such as preventary tests twice a year, for example, blood test, urine sample, to assess, predict, or to observe on an initial stage some pathologic changings in our tissues, organs, organ systems. And what is most important, in countries of low economical development, in societies with low income, we have very small possibilities of both preventing and educational work with society members. So you see, public health implementation and elaboration of public health projects, defining the public health policy and informing public health arena is the main and decisive and central healthcare understanding, totally based on research. That's why when we have pandemic situations, such as we found ourselves today, that's why we have this distance learning with you. The demand for the new research data is so much increased that researchers have no time to publish their data in peer-reviewed journals, and they are publishing them, uploading them on preprint databases. Okay, so when you see some information which is uploaded on preprint databases, preprint from the definition you can easily understand that it's not printed. In parentheses, you always have indications that this data is not peer reviewed. It means that as biomedical sciences are evidence-based sciences, and as biomedical research data is evidence-based research data, if it's not peer reviewed, that means if it's not evaluated by field experts, you cannot fully trust them. And if you use this data as a source, as a reference for your publication, you should remember that reviewers would underline it as a weak point of your publication because it wasn't peer reviewed. That's why we say that one step is, and very necessary step, to disseminate rapidly new research data, because researchers sometimes, for example, in case of pandemic, they can wait 3 or 6 months to publish their data because everything changes very frequently, and new research data may facilitate new clinical approaches. New research data may promote new understandings in building of treatment protocol. For example, which is sufficient factor or which is necessary factor in COVID infection. You need to know this. And how are you detecting this? How are you understanding and finding and discovering this? By research, doing your research. And clinical professionals, they need the data rapidly. That's why you upload as a researcher on Prempeh database. At the same time, you are estimating the risks because it's not reviewed, it's not evidence-based. Okay? So you see, these are two different poles of understanding, two different mechanisms which interact. And that's why we say that research is a decisive and central factor in understanding the nature of disease, in understanding the possibilities of human organism to survive, to adapt itself with new conditions, with change homeostasis, because chronic diseases, they change totally our biochemistry. For example, diabetes type 2 or chronic liver inflammation. Now imagine that patient suffers with chronic liver inflammation, and at the same time patient has to receive daily some medication to treat arterial hypertension, which is eliminated from organism by liver. So the function of livers are decreased, the possibilities of elimination are decreased because of chronic inflammation. At the same time, patient has to receive the medication, which for metabolism and elimination needs normal liver functions. So you see, in this case, doctors and patients, they are estimating risks. And this is called, in public health, this is called risk estimation and management. So to manage risks, we have to find out which is a necessary factor of this disease, which is additional factor, which is sufficient factor. And then we try to manage this situation. That's why research data is imprescindible, it's crucial, it's central for managing any time or any sort of information. And we say that we have to do our best to support and to provide clinical departments with our new research data, because without this, without the understanding of main causes of diseases, it will be absolutely impossible for clinical professionals to treat diseases. So this is one very important thing which I wanted to discuss today. Also, we have to pay attention on such interesting topic as literacy, scientific literacy. So what is scientific literacy? When we are speaking about new information and information literacy, we are speaking about which sources we can trust. So which sources are trustable, which sources represent validity, valid information, which are valid by their very nature. And scientific and information literacy also means that we have to understand the demand for new information. Why researchers start researching? Because they understand that there is a gap somewhere. For example, we need to create a new vaccine for COVID-infected patients, and not only patients, but for population which is not infected yet, to prevent the dissemination of virus. So as this virus is highly contagious, we need to create a vaccine. So we see that vaccine is a gap. This is necessity, which we understand. Then we have to find the way how to bridge this gap. And we are doing library research. Before we start our own research, we go to libraries. And please remember, there is a lot of controversy about the point of how electronic sources can change the understanding of the notion of library, and how electronic sources can substitute the printed sources. So one of the main recommendations, not only in case of social sciences, humanities, etc., but also in case of biomedical sciences, is not to rely fully on electronic sources, is to remember always that electronic sources have their own idea to be created. The same preprint databases. We say that the main idea of preprint databases is rapid dissemination of new research data. But together with electronic sources, we have a lot of sources which are not in open access. We have to have subscription on journals, on special literature. We have to buy books, monographs, to read new approaches. And this is called information literacy, to find out that we need a new information and how this new information may be collected, later sorted. Or does it mean to sort the information, to put it on the shelves? You need to define for yourself where to look for this information, where to look for, because there are different possibilities in contemporary scientific system to keep the information. For example, scientific databases, they are indexing different journals and monographs and volumes, coordinated volumes, which are later very useful for proper research, both for collaboration, being national or international. So once you define the need for your information, then you have to find out where to look for this information. For example, we have Medline, PubMed, different databases. Databases may be multidisciplinary or not. For example, PubMed is only medical database, but there are different databases like Scopus, like DLNet, like Thomson Web of Science, which now is called Clarivate Analytics. So these are databases which are indexing journals from different sciences, both from biomedical sciences and from social sciences. And then you have to collect information and sort it, put it on the shelves. After you are defining why are you sorting this information, you are defining which part of the information will be used for your research. For example, for the introductory part of your research, you may use first 15 articles. For materials and methods, you may use next 10 articles. To formulate conclusions, you need to base on something your conclusions on the work done before you. And in this case, you need to formulate, to use some another 10 articles. And this is called information literacy. Okay, it's absolutely needed. And this information should be updated. You cannot use information published 5 or more years ago, because in biomedical sciences, the information is accumulated very rapidly using a cosmic velocity. In humanities, you can use texts of Heidegger, of Plato, and be modern because you are interpreting them. Because humanities and social sciences, they are based on interpretation, meanwhile biomedical sciences are based on knowledge. And what you have to take into consideration is a newly created knowledge. Okay? Knowledge management, which does not form part of our studies, is another field of studies which understands the creation and dissemination of knowledge, which is done only by research. The only instrument to create and disseminate the knowledge is research. Without research, there are no possibilities of creating new knowledge, even in humanities, even in history, even in philosophy, in social sciences, in demography, in sociology, in economy, in business and law, in everything, in IT technologies. We are experimenting. We are doing our individual new research, which is totally based on previous research. And either we are discovering something new, or we are improving the discoveries of previous researchers. For example, X-ray was a discovery, and it was and it is actively used in contemporary medicine, and probably it will be used in the future century also. Okay, we are adding some new inventions, some new improvements such as computed tomography, MRI, PET, but X-ray has its own place in diagnosis, in monitoring. Or a lot of vertebral pathologies are monitored by X-ray, for example, especially in pediatric practice, in children. When we see the different abnormal developments of vertebral column, we use X-ray, both for diagnosis and for monitoring. For example, once a year, we're making new X-ray picture to monitor the deviations, the abnormal or normal development, the improvement. So it's facility to estimate in dynamics the development, both normal and abnormal. So what I wanted to discuss in this lecture is the main cause of disease, main factors, necessary factor, sufficient factor, contributing factor, the importance of defining factors, how these factors are acting, are they acting alone or are they acting in combination? And all these we need to understand the very nature of disease, to elaborate the treatment protocol, and later to observe when the patient leaves the hospital, to observe and to facilitate the psychological rehabilitation of patients, because we are not only physical beings, right? Our biochemistry determines both our functions and our mood. Our behavior is mostly determined by our biochemistry. So I hope this was interesting for you. And as I continue receiving questions concerning the material for the midterm, I want to repeat it here that you will have to revise chapter 7 and 8. Okay? So thank you for joining. I think, if I'm not mistaken, you will have your first midterm next week. I wish you luck and peaceful holidays. Thank you for joining, and hope to have possibility meet you next Saturday at 11. Bye.